Good evening, everybody. Welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. Can you hear that? So we're just experimenting with some technology and I'm getting a bit of a feedback, so bear with me. If you can hear it, shout at me. Welcome. There are a few people joining us online and a few people present in the room. So I thought it would be a good idea to do some introductions. I'm going to start with Gillian. I can see your face now. Gillian Kay, our new Director of Wellbeing. Thank you very much indeed, Gillian, for joining us. Do you want to say a few words?
Yes, thank you very much. Delighted to be joining you. I joined BCP Council last month as Corporate Director for Wellbeing, and it's excellent to be here. I'm really sorry not to be there with you in the room. Normally would aim to be there, but tomorrow morning I'm attending a conference of ICS networks. So I'm immersing myself in the world of the NHS and hoping to bring some learning back to BCP with me. But I very much hope to be there with you in the room next time in the new year.
Thank you very much. I'm just going to pick people at random on the screen first, if I may. Sarah, would you mind just introducing yourself?
Yes, good evening, everybody. My name's Sarah Webb. I'm Head of Statutory Services for Adult Social Care.
Thank you. Sian?
Good evening, everyone. I'm Sian Walker-McAllister, and I'm the Independent Chair of the BCP Safeguarding Adults Board.
Nikki?
Hi, hello everyone. I'm Nikki Mitchell. I'm Head of Transformation and Integration for Adult Social Care, and in my area is complaints, and that's why I'm here this evening to present that report.
Thank you. And Louise?
Hi, I'm Louise. I'm the manager at Health Watch Dorset. It's nice to see you all.
Okay, thank you very much. We're just going to do some intros. We are expecting Councillor Salmon to join us online. I can't see you. Oh, there you are. Do you want to just introduce yourself, Joe?
Oh, hey, yeah, sorry I'm late. I'm Joe. I'm the ward councillor for Moordown.
Thank you. Hazel, you okay over there? You okay over there? Yeah, that's fine. Phil, would you mind just starting?
Thanks, Chair. Hi, I'm Phil Hornsby, Director of Commissioning for BCP Council.
Hi, good evening, everybody. I'm Betty Butlin, Director of Adult Social Care in BCP Council.
Hello, everybody. I'm Kate Calvert, and I'm the Acting Chief Officer for Commissioning at NHS Dorset.
Good evening, everyone. I'm Rob Payne. I'm Deputy Director of Strategic Commissioning at NHS Dorset.
Yeah, evening all. Matt Baker, Principal Lead for Primary Care, NHS Dorset.
Hi there, Councillor Leslie Dedman, Ward Councillor for Muddyford, Stamford and Highcliffe.
My name's Patrick Canavan. I'm the Chair. I'm a Ward Councillor in Boscombe West.
Hello, I'm Sharon Carr-Brown. I'm Ward Councillor for Queen's Park.
I'm Cameron Adams, Councillor for Kinton.
Matt Gillett, Talbot Woods.
Councillor Paul Slade for Creekmore.
Hi, Councillor Chris Matthews for Kemford Heath.
Councillor David Brown, Ward Member for Bearwood and Merley and the Portfolio Holder for Health and Wellbeing.
Okay, thank you very much, everyone. I'm going to ask the Democratic Services Officer to read out the housekeeping notice, please.
Thank you, Chair. Please note that this meeting of the Health and Adult Social Care Overview and Scrutiny Committee is being recorded by the Council for live broadcast and will be published on the Council website for a minimum of 6 months. The meeting may also be recorded or streamed for live or subsequent broadcast by members of the public, although ultimate discretion in this matter lies with the Chair in case of disruption. For those in the room, please note that if the fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the surface car park at the front of the annex. And finally, please ensure background noise is kept to a minimum and mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you.
Thank you very much. And do we have some apologies?
Yes, Chair, we've received apologies from Councillor Jackie Edwards, Councillor Judy Richardson and Councillor Dwayne Farr. And as you previously highlighted, Councillor Salmon is attending remotely this evening. And substituting tonight is Councillor Cameron Adams, who is substituting for Councillor Dwayne Farr.
Oh. Welcome, Councillor Adams. Okay, are there any declarations of interest, please?
Yes, I need to declare that my husband is a member of the ICB board for Dorset, and I am in receipt. I'm a support worker to a man who receives direct payments from BCP Council.
Okay, thank you very much. Are there any more?
Oh yeah, so I work for Dorset Healthcare, so I've got to say that, haven't I, every week, month, whatever.
Okay, thanks, Joe. Right, we're going to move on to item 4, which is the confirmation of the minutes. So unless anyone indicates otherwise, may I assume that everybody's content that I signed the minutes as an accurate record? Everybody happy? Thank you. So the action sheet is 4A. And again, if anybody has any issues, could they please say? Otherwise, we'll take those and assume those that that's a correct note of the actions that we agreed. Again, everybody happy with that? Okay, thank you. Public issues. Are there any public issues?
There are no public issues, Chair.
Okay, thank you. Then we're going to move on to item 6, which is the Dorset and Bournemouth, Christchurch and Poole Safeguarding Adults Board Annual Report. And I think, Sean, you're going to kick us off with this. Thank you.
Thank you very much, Chair. Our Board Business Manager, Glynis Greenslade, is going to put a presentation up on the screen. If you can put it on the full slideshow, brilliant. Thanks. Thanks very much. So, as I said in my introduction, I'm the independent chair of both boards. We meet together as one board because we have many statutory and other partners who cross over the boundaries of Dorset and BCP council areas. And we retain the ability, however, to meet separately. So if there are place-based issues, we can in fact hold separate meetings for either BCP area or Dorset area. I am appointed, I work about 4 days a month and hold the council, as both councils, as well as the other statutory partners and other partners to account to ensure that they're all working together to effectively safeguard the population in our area. And when we talk about safeguarding, there's one thing I always like to clarify at the beginning. Safeguarding as defined within the Care Act 2014 is very specific in respect of adults. Safeguarding adults is about safeguarding those adults with care and support needs who, because of those care and support needs, are unable to protect themselves from abuse, from neglect, or from harm. And often I get asked questions about safeguarding when that doesn't necessarily meet the criteria for the interventions of partners. The role and the function of the board is a statutory board to hold partners to account for delivering against those services, against that definition as defined within the Care Act. So if we could go to the next slide, please. Which just sets out the 3 statutory duties defined by the Care Act. So we have to develop and publish a strategic plan setting out how we meet our objectives and how our members and partner agencies will contribute. And then we publish an annual report detailing what we've done in the previous year. And this annual report is in respect of the year 2022 to 23. So it ended on the 5th of April. And we spent from April to July pulling the report together. It's been through our board governance process, and it's provided here for you to ask questions and to check that we're doing what we should be doing. But primarily our statutory duty is to report to the Health and Wellbeing Board and to show them how we've delivered. The other statutory duty we have to undertake is to undertake and commission a safeguarding adults review. If somebody's died or suffered significant harm and this is the important bit, it appears that agencies have not worked effectively together. So members of this committee may be aware of many issues, sadly, where individuals may have died or have taken their own life, but where there is evidence that agencies have worked well together. The purpose of the board is to pull everything together for learning when that is not the case. And at the current time, we're undertaking about 3 safeguarding adults reviews across Dorset and BCP. And during this year in question, we published 1 safeguarding adult review, which is highlighted in the report. Can we go to the next slide, please, Glynis? The next slide, have we not got the slide on the strategic plan? First of all, that should be the next one. I think you've jumped to the, no. Okay, so in your annual report, I'll wing this one. In your annual report, the strategic plan is set out as it was for 2021 to 23. We generally deliver a 3-year strategic plan because, as with many boards, issues either roll over because we need to undertake ongoing work, or we need to ensure that we continue to highlight issues of importance to our partners, that the work we've done in one particular year is not sufficient by and in itself. So our strategic plan for this year is set out in the annual report, and then what I've set up here is the performance information in respect of BCP council area. Now it says BCP council, but it is in fact the council's area. Now what I should say is that adult social care within BCP council is the lead strategic partner for adult safeguarding. Many of you will be aware that in children's safeguarding there are 3 strategic partners who work together equally. In adult social care and adult safeguarding, it's adult social care that are the holders of the data and to whom all safeguarding concerns should be referred. So this is a snapshot on a page outlining where concerns, as defined under section 42(1) of the Care Act, are referred, and how those concerns are broken down in terms of the types and locations of abuse, gender and age, etc. And then it sets out those concerns and how they and those that progress to a section 42(2) of the Care Act inquiry. So in explaining the difference between concerns and an inquiry, many people report safeguarding concerns because something doesn't feel right and they want to make sure that they raise concerns appropriately with the authorities. It's often the case that that a safeguarding concern is referred when perhaps another action might have been appropriate. And indeed in BCP Council, we know from our analysis of the data and of the trends as shown over this last year, that many of those concerns were responded to by maybe a referral to the voluntary and community sector to a specific organisation that could help, a referral or discussion back with somebody's GP, or a Section 9 Care Act assessment. So the person, a number of others who made the concern were worried that the person needed a Care Act assessment. They weren't coping very well at home. They referred it as a safeguarding concern, but it was dealt with by a Care Act assessment, and then the person is engaged from that moment on by the adult social care contact team, and then the care plan, if it was felt appropriate, put in place and monitored by that team. What we can see in terms of in this data, the source of risk breakdown, is that 25% of the concerns that have been referred are from service providers, and those are generally social care service providers. And you may say, oh, this is really worrying, a quarter of all concerns coming from providers. I'm actually not worried about that. What this is telling me, and indeed when we interrogate the data and talk with senior officers within BCP, we know that there are very excellent, very effective working relationships with social care providers by the council. And actually this encourages providers to refer a concern, appropriately so, and it may be that somebody's had an unwitnessed fall, or there's a concern arising from their contact with a member of their family whilst they live in a care home, and that's appropriately been referred to adult social care for triaging and for considering whether there needs to be a Care Act inquiry. What we also know is that 65% of those who are referred to as abusers or as perpetrators will be known to the individual. It's very common, and that data is benchmarked up and down the country and very similar to the data that that is produced for other safeguarding adult boards. I should say that I have chaired quite a few safeguarding adult reports in other boards in other parts of the country, and work nationally with safeguarding adult board chairs, chairing the national network. So I get to see this data, and I'm able to easily compare the data coming through BCP to other national data. Only 9% are unknown to the individual. 28% of the types of abuse in BCP are neglect and acts of omission. That is again data which compares equally with other safeguarding adult boards up and down the country and with other adult social care departments in the country. 16% is financial or material abuse, 15% physical, and 13% psychological. So it's useful to have the breakdown. It enables us to dig down into the data further. And in fact, our quality assurance subgroup of the board has the opportunity to look at this data, to map it, to discuss with other partners who are working across our BCP council area, and to identify whether there are areas which might require a deep dive audit or some more work to try and understand the trends and try and understand, is there something else that as a collective, as a partnership, that needs to happen, which will be coordinated by the board, and which needs to happen to understand neglect, abuse and harm in our BCP communities. 57% of the locations of abuse are in someone's own home. And again, that's not something that I would be really overly concerned about. Many older people in particular are living on their own and are living with comorbidities, with frailty at home, and a concern may be referred that they perhaps are not coping, and there are issues going on, or it may be that they're being abused by a family member or somebody else who has an interaction with them. But that's very common, that abuse, the main location of abuse is there. 13% in care homes, 11% across other areas. We're doing some work this year to work, in fact, it's, I say the royal we, it's Sarah Webb and her staff are doing some work to understand the other and how that is represented, because often staff, when they're recording data, will record other if there's not something that jumps out. So we're trying to understand that a bit better to make sure that there are no gaps that we're missing. And 8% of abuse happens in the community, and that's not in the person's own home, it's actually out in the community. Women are nearly twice as likely to be the subject of a Section 42.2 inquiry, and that's very common up and down the country, and primarily because women tend to live longer than men and are more frail towards the end of their lives. and 48% people are aged over 65. So you won't be surprised by that data. So during 22-23, the board has been conducting 2 safeguarding adult reviews, Aziza, which for which there is a précis published in this annual report, and you can access the full report on our website. Aziza was a student, it's a pseudonym, was a student at Arts University Bournemouth who took her own life, and there were a numbers of areas of learning in respect of that review around how statutory agencies and partners communicate with younger people to make sure that they engage better with them, how we understand the plight of students around money and accessing prescriptions and those sorts of issues, and how the higher education sector works effectively to prevent abuse. And we had a lot of assurance with Sarah Ziza that the universities were doing an incredible amount of work. And as a result of this Safeguarding Adult Review, indeed before it was published, we decided to set up a regular meeting outside of the formal board structure with the higher and further education sector to make sure we were able to communicate well, and that sector understood how to communicate with adult social care to raise concerns and how to escalate issues if there were concerns that a student perhaps wasn't being supported in any sector, whether that be by the GP, through hospital, or attending community mental health support. So we absolutely captured the learning from that review, and that learning goes on. We are undertaking some more SARs this year, and they'll be published. The ones that are completed within this year that are coming to the board in the next couple of weeks will be published in this year's annual report. May I go to the next slide, please? So this is the slide I was referring to earlier, the strategic plan for that year. You will have seen it in the report. I'll skim over this and go to the next slide. Thanks, Glynis. So some achievements during this year. We worked very effectively. We've been working since I joined the Safeguarding Adult Board as its independent chair. I made a commitment that we would have a subgroup called a community engagement or community reference subgroup to make sure we had the voices and held the voices of people with lived experience of safeguarding, and particularly somebody we term as the unheard person, people who perhaps don't express themselves, and the things that we could do as a board to make sure we reach out into communities far wider to have those views held and respected and adhered to within the work that we do across the partnership. So that group has gone on from strength to strength this year, has been co-chaired by the Dorset and the BCP voluntary and community sector lead bodies, and we've been engaging very widely with other voluntary and community sector groups, and I think we need to do much more to engage with people with lived experience themselves, so we can get perhaps a small group of people who'd like to join in with the group and perhaps help us look at some of our policies, some of our communications, to make sure we improve everything that we do to communicate more widely within the BCP area. I've talked about higher and further education. We also commenced engagement with the registered social housing provider sector and faith groups in this year. And this most recent year, we've capitalised on that. And we now have several groups that are meeting outside of the board where we can communicate more effectively on safeguarding. We publish what we call 7-minute learning papers, and that's not intended to be facile in any way, but we recognise that very busy staff working on the front line often don't have the time to read tomes or sort of 23 pages of document or policy, and I feel it's something I'm particularly passionate about, that we make sure that we refer to the longer document, but that we publish a 7-minute learning so that people at a glance can understand the key issues and know where to look for more information. So the two we've published in this year were on understanding homelessness and exercising professional curiosity. Really, really important issues that have come out within our Safeguarding Adult Reviews and within Safeguarding Adult Reviews nationally. We've worked alongside the Dorset Healthcare Forum for professionals working with people with complex behaviours, and I've been to present to their group. We've delivered a Safeguarding Adults Week with some keynote speakers. We developed a new information pack for board members so that board members are very, very clear about their role in the partnership. And we attended the Pan Dorset Safeguarding Children Partnership Executive Development event. And it's really important, and one of the commitments, again, I gave when I joined, that we work closely with the Pan Dorset Safeguarding Children Partnership and our community safety partnerships to make sure that we don't work inefficiently, that we understand each other's priorities. And when there are reviews, we look at one overarching review and see how we can passport that through the other statutory boards to make sure that we're not repeating work, repeating engagement with vulnerable people, and importantly, that we're all learning together. We delivered a very reflective development event with an external facilitator, and that resulted in a new strategic plan which has been produced for this year, which kind of acts springboards, if you will, off the strategic plan that is before you in this last year's annual report. Next slide, please, Glynis. So we published Sarah Ziza, we delivered a training strategy. Very important to recognise that the Safeguarding Adult Board doesn't have to deliver training, but it does have to have a strategy around safeguarding adults training to which it holds all partners to account. And one of the areas that we have noted in this last year and we're delivering in this year is that there's been a dearth of training and a need for refreshment of the protocol around multi-agency risk management. So we're doing that work now, but that's certainly come out of the strategy and out of the work that we started during this year. We reviewed our board's business arrangements to ensure we were delivering our safeguarding strategy effectively. And now, and I'm really grateful to BCP Council for this, BCP Council hosts the business team. Sarah Webb is a strategic lead for that work. And Glynis Greenslade and Faye Ware and Claire Hughes, all working part-time, are the three officers who work within that tiny team to help us deliver across Dorset and BCP. And our funding comes from Dorset, BCP and our other statutory partners. Really important piece of work started in this last year, and it's looking at the NHS DICE information. So that's the data that the NHS collects. And we've now started plotting our safeguarding adults data over the DICE data that comes in. So we understand the demography in our areas. We understand areas where there are social deprivation. We can map out issues around homelessness and safeguarding, substance misuse and safeguarding, for example, and know where we need to target our work and the issues that we take forward as a board. We updated safeguarding adults policies and protocols, and we commenced delivery of improved board member engagement because we were meeting virtually with the pandemic when that was upon us, and now we meet in person twice a year, which I think is really important. The ability to kind of work face to face, to be able to read and understand people's body language when you're working with them, and to work on our strategy together. So we have 2 in-person meetings a year. We've delivered considerable assurance on the delivery of making safeguarding personal. Bit of jargon for you. Often you'll see it described as MSP. What it essentially means is that, and it's defined within the Care Act, is that whenever somebody receives a safeguarding intervention, that we will work with the person or their advocate to try and understand what outcomes they would like to have following the safeguarding intervention. How would they like to be supported to be safer? What do they want from all our engagement with them? And it's not just a tick box exercise in terms of asking them. It's about really making sure that all the work in safeguarding works from a strengths base, so that that practitioners work with people to understand what people first of all can do for themselves, and then where we may assist where we need to make them safer. And all bound up in that is people's ability to be able to make decisions for themselves, and that is clearly defined within the Mental Capacity Act, and how we work to assess mental capacity, to support people to make decisions where they can, and where they are unable to weigh up decision making, to be supported to have decisions made in their best interest. So the QA subgroup oversaw the delivery of the audit of MSP, and we have agreed that delivering MSP will be strengthened through training and development, and not just training and development focused on making safeguarding personal, but all training and development. And that's training and development delivered by all our agencies, as well as the small bits of training that we deliver as a board. We did focus on it at our development event. The next slide, please, Glynis. So I want to leave you with some key messages, and the first one is that something I said at the beginning, which is that I hold all partners to account. So even though as a registered social worker and as a former director of adult social services myself, my tribe, if you will, is social work and social care, I actually am very robust in holding adult social care to account in both BCP and Dorset councils for the work that they do, as well as our NHS partners and police, the 3 statutory partners, and then all the other partners who come together in the board. And those include the housing directors in both local authority areas, prisons, probation, the voluntary and community sector. I probably missed several out, but the detail is contained within the annual report. Working in a partnership way, I think, is really important, and it's also really important that I, in my role, identify areas to ensure that every single partner in the board feels that their issues are being dealt with and have a focus. And so we did a piece of work recently in looking at the prisons and safeguarding in preparation from discharge from prison, and that's going to feature in an event that we're going to hold next year about how we support both our communities to ensure safer communities, but how we support people who've served their sentences to be discharged appropriately and supported appropriately. Often many of them have neurodiverse needs, have mental health needs, and need support as they adjust to life back in the community. So that's one of the areas that we've attended to. We're doing a lot of work with our with the integrated care system and the integrated care board around holding health care providers to account, and work with the police on their delivery of right person, right time, in making sure that when somebody is in difficulty, that the right professional is contacted and is able to attend them to be the first point of engagement. And much of this work is currently in train this year as well. So going back to the statement I made earlier about the 3-year strategic plan is important because things bleed over into other years. Actually, the former strategic plan coming into this one as well, there'll be some similar themes coming forward. And I mentioned before about strategic engagement with the other statutory partnerships. The next slide, please, Glynis. And it's questions. So thank you very much. I hope I haven't gone on too much. I'm passionate about this area and about us getting it right, and passionate about partnership working, and I'm really happy to take any questions that you may wish to ask.
Thank you very much for that, and thank you for the report. I'm just looking to see if there are any questions. Councillor Carr-Brown.
Can you take the report down, please, Glynis? And then we can see full screen. It's easier. Thank you.
Hi, thank you very much for that. I'm new to this, so I may ask an obvious question, but I'm going to ask it anyway. So I was looking at the performance information, the infographic, and I was particularly interested in the contrast with Dorset, between BCP and Dorset. Like we're collecting slightly different metrics. I wondered why that was. For example, in the risk breakdown, we don't have the self category, and I would have thought self was quite a significant risk. I wondered how we saw that, if we can see it. Also, things like you said you weren't too concerned about 57% in their own home, but in Dorset it's only 43% in their own home. So perhaps we should be more concerned about that. I don't know. And also we have 48% are people over 65, but that means actually more than half the people are under 65. And I think a lot of people would be surprised that actually it's younger people that are also, you know, I think a lot of people don't realise just how many younger people we look after. It's not all elderly people. So I wondered who the most vulnerable, the single most vulnerable group was. You know, what is the level of data that we have in that respect? I mean, it's mostly the contrast between what we're collecting and there wasn't sort of any reflection on the differences between us and Dorset. For example, 28% neglect and accident and omission for us, 51% for Dorset. Yeah, just some comment on that would be helpful. Thank you.
So thank you. It's a really helpful question. So comparing local authorities' collection of data and the submissions they make in the Safeguarding Adults collection each year is like comparing apples, pears, cherries, walnuts, and anything else you can think of. And whilst NHS Digital, that oversees this information, has been trying to do some work to improve this, data up and down the country shows that because there are different arrangements at the front door of each local authority for receiving safeguarding concerns, we're never going to get it exactly right, and each local authority isn't mandated to collect data in a specific way. However, where I want to give you assurance is that first of all, we neither do we specifically compare or benchmark BCP with Dorset, because the demographics are very, very different as well. But they collect the information differently and deal with it differently. The response to some of this question I will field to Sarah Webb, my colleague and your head of statutory services, and she can explain how the data is collected at the front door for which she is responsible in BCP Council. I think the important thing is that we have the data, that we ask the questions, and then we decide whether we need to be concerned in a particular area. I meet separately with Sarah and with her opposite number in Dorset to scrutinise the annual data in each case and have an understanding of at those meetings of how that data is broken down and how they collect it. But it's not the single most in terms of the areas of concern needs to be, I think, with older people living in their own homes, and also people who are difficult to find it difficult to engage with statutory services around help and support with their needs, which might be substance or alcohol misuse, homelessness, and an area that you highlighted, which is really, really important, which is transitional safeguarding for us. So it's young people who have had support in one way or another whilst children, may not necessarily have a specific disability, but may have experienced early childhood trauma, which impacts their mental health, and where there's not some visible disability, but where we need to be ensuring that staff on the front line recognise that when a safeguarding concern is referred, and that they are then referred to the appropriate agency for support. So I'm going to ask Sarah to come in to answer part of that question, if I may, Councillor, and thank you for raising those important points.
Thank you, Sean. I do apologise in advance if I have to put myself back on mute. I have a bit of a cough at the moment, so I'll try not to deafen anybody with that. I think perhaps if I could just very briefly explain how adult social care deals with the contacts that we receive that relate to keeping people safe. From our front door all the way through our services, if we are given information that suggests that somebody needs help to keep themselves safe, so we will call that a safeguarding concern. So that's the point at which something is counted as such. And I think Sean already inferred that not all councils take that approach. The reason we take that approach is so that we can then track the intelligence that information gives us, and we can also track what the outcome, what we did with that information much more easily. So if we receive a safeguarding concern, as you can see from the data, it doesn't necessarily mean that that will progress to a Section 42(2) inquiry. It may be that we hold the information for intelligence, for information. It may be it's not an appropriate referral, or it might be that we refer that on to another intervention. And that could be a multitude of different interventions. But I think the important bit for me, again, that Shana inferred earlier in her presentation, was that we do have a really good reporting mechanism locally. So there's been a great deal of work done across all of our providers and our partner agencies to encourage and members of the public as well. There's been campaigns of sharing information about how to raise concerns with the council, and that has resulted in us having quite a high number of concerns being raised with us. But that gives us really rich data. I am happy to take any subsequent questions around that particular issue, but I know that there was also a question. I'm just trying to find my data. There was also a question around the types of challenges that people face in terms of there was a large proportion of people that were over 65, but what about all of the other people? I haven't directly got in front of me the breakdown of ages, but in terms of what we call the primary support reason, so why a person may have care and support needs. So the main reason during the last quarter of why people were in contact with us was because they had physical support needs. So there was around 30% of those people that needed a Section 42 inquiry had physical support. And then next were groups of individuals that had mental health issues. And then third were people that had memory or cognition issues. And then fourth were people with a learning disability. So that would be the whole age range from 18 through to no longer being with us. So I hope that gives a little bit more indication of the sorts of ranges. Are there any other specific questions that...
Sarah, if I may also add, we've done a particularly good piece of work this year in identifying transitional safeguarding as an issue that we wanted to promote to our staff to make sure that, because there's evidence up and down the country, not just in one particular council area, that those who transition from children's services get a bit of a poor deal sometimes in terms of support with safeguarding when they reach 18. So the younger age group that you mentioned is really important. And Sarah and her team did a piece of work with children's services in BCP to enable us as a board to develop a transitional safeguarding position statement. So it very, very clearly and succinctly explained what transitional safeguarding is.
Thank you, Sean. Yes, we've done a lot of work with colleagues to engage and make sure that we can support people who may fall through the net of other services. And I I think I'm right as well that, Councillor, you mentioned something about self. if I heard correctly. So, but did you mean self-neglect?
I was contrasting the breakdown from BCP and Dorset, because in the risk category, sources of risk, they have 11% as self, and we don't have the category at all.
We do have the category, but it's not one of the, I think it's the top 4 that Sian referred to in her report.
No, on the infographic there are 3, and risk and self isn't one of them.
Okay, but we do count self-neglect, and it's an area that adult social care have spent a lot of time developing and working on from the point of view of improving practice. We very much recognise the need to support people who find it difficult to look after themselves. We have something, a forum called a self-neglect and hoarding panel, and that's a specialist panel that will work with practitioners and people who are finding it particularly difficult to engage with services. And the purpose of that is to try and find a solution-focused approach to help people to take care of themselves in a more productive way, and to reduce the risk to self.
Sorry, just to follow up on that very quickly,
Yes.
if you add up the percentages, they add up to 99%, so I'm not sure where the self is.
Okay,
I think it comes within neglect and acts of omission, doesn't it? Yeah,
it's not listed
so
there either.
It's not been separately accounted for. But what we'll do, I'm really pleased that you raised that, and what we'll do is make sure that we've got the data for that separately accounted for next year. I think the point I was making though was that it's very difficult to compare BCP with Dorset, but actually it helps because it ensures that one is challenged to make sure that we nothing has slipped through a gap. And self-neglect has absolutely been something that we concentrate on as a safeguarding adult board.
I think my understanding, apologies, just to clarify, that self does come on Dorset councils because it was within the top 4 sources, whereas for BCP it's not within the top 4. It doesn't mean to say we don't count it. Does that help?
Okay, well that then says it's less than 1%. Okay, that's fine, thank you.
Okay, thank you. I'm going to take Councillor Salmon, please.
So yeah, similarly, I would also like to question that data. And so is it that, just to clarify, Dorset and BCP use different systems for reporting safeguarding? Is that why we can see? Okay, so I get that creates some kind of artificial discrepancies within the figures we see, but is there a way we could stratify this data because of the demographic differences? So we could see that, and that would be something nice to see in next year's report. So for example, we've talked about older people in their own homes. It would be nice to see a breakdown of stratified data for older people in their own homes, you know, this type of data sliced up in that way, if that makes sense.
We can have a look at, we can certainly have a look at that with the DICE data that we're and the support with NHS Dorset. I think we don't have so the board doesn't have its own data analysts. It relies on the work, the data analyst input from BCP Council and from Dorset Council. And I'm just going back to thinking about your colleague's comment about that's less than 1%. I think perhaps what's not clear is that the top four splits in the way of 28, 16, 15 and 13. It's not that they are percentages.
I think we're talking about sources of risk breakdown rather than top 4 types of abuse. That's the issue, isn't it?
And we've always in the past, and indeed before I came to chair this board, reported as part of the annual report on the top 4 types of abuse in each area. So, but I think it's a really good idea to be able to get the analyst support to be able to help us to break down that data. And I'd really welcome if this committee wants to think and you know in your own development time or your own discussions, think about where it might be more helpful to see if we can then break down the data differently for next year. I'd welcome that challenge.
Because it looks to me like the BCP data self is included in known to individual. That would be my gut feeling. That's how I reckon the data is being collected for BCP. I'm really curious though that even though there are demographic differences and there are two different systems being used, if you look at the conversion rate for concerns received, I mean, one, Dorset, they deal with everything as other safeguarding inquiries under section 42.2, whereas BCP, we only do 5 of those compared to their 3,000 odd. But the conversion rate of concerns received, you look Dorset, their concerns received almost 50% turn into a section 42, and it's, I don't know, can't do it in my head, but it's definitely significantly less than 50% for BCP. I'd like to understand, is that what you can explain that through demographics or the way?
No, it's the way that the councils differently collect the data. So, for example, there was one council probably a couple of years ago, because I've been doing some national work with NHS Digital on this, that said that they 100% of concerns went to inquiry. Well, that's not the spirit of the Care Act in terms of how that data is gathered. And when you dug down into that data, it was because they were triaged off at the earlier stage, and they only counted those safeguarding concerns as concerns where they met the criteria for inquiry. So it is counted very differently in every different local authority, and that's not helpful. What is important is that we work with local analysts to make sure that the board scrutinises the data through its quality assurance subgroup and identifies area where we feel we need to do more audit to understand what's going on locally. So that's the purpose for us as a board in getting this data. I don't think it's helpful to compare Dorset and BCP, other than to have it as an opportunity for anyone outside of the board, or indeed in the board, to say, well, look, this is different. Does that mean you collect it differently? And to then go down those different ways of understanding why we collect it differently. I don't think we're ever going to be in a position where we're going to get agreement between councils to collect the same data, because they all have their own different priorities and different systems of working. But what is important, as you say, is to be able to get a better understanding of why that is, what the data is really showing us.
Next year, I'd really want to see that explanation as to why the differences exist and some stratified comparisons of the data. But as well, I'm very curious about trends, which I might have missed it reading the report, but I'd be curious, is this going up? Is this going down? Are we seeing more safeguarding, less safeguarding? Are we seeing a trend towards, and at what, is that, it would be nice to be able to compare that to the rest of the country, much as it's difficult. Are we seeing an increase in safeguarding that makes us an outlier? Particular types of safeguarding.
You can get an understanding of what's going on around the rest of the country. There are increases in concerns. There's increases in statutory safeguarding adult review referrals and the undertaking and commissioning of those. And that is because people are more aware of adult safeguarding and of the requirements under the Care Act than they were when it came into being 8 years ago. Children's safeguarding has been on a statutory footing for far longer, and it's much more simple because it's everyone under 18, whereas in relation to adult safeguarding, the whole issue around mental capacity comes in, the ability to take unwise decisions, how we might support people, and the definitions around care and support needs, and how and agencies working together. So it's very, very different in safeguarding adults. But what we can do is I can ask the directors of adult services in both Dorset and BCP to see if we can have the data analysis capacity to enable us to get some of the data for next year's annual report. We don't have it within the board itself. We have to go to the council to get that.
Final question. Just curious. I'm curious
I'm
about
quite
risk
keen to
removed,
move on,
reduced,
Joe.
and
Can you make it brief?
very quickly. I just want to understand what we mean by risk reduced, removed, and remains in each of those. Are those the same thing across the data sets? And what's the difference between a reduction and a removed and a remains? I can't see what the difference between reduced and remains would be, to be honest.
Well, it's not always possible. So somebody could make a decision that they want to continue living with their son who's been financially abusing them, as an example. But so the risk might be reduced because the social worker who's gone in to undertake the work and provide the safeguarding support plan might have then made arrangements with the Court of Protection for power of attorney to be revoked and the Court of Protection to undertake financial responsibility for the person who wants to continue living with their son, but is no longer at risk of financial abuse. So what we do is we ask people, so I say we, I'm owning the role we here. Sarah's staff work with people. They don't ask them directly in a hard way, but to understand how risk is reduced or remains. And for some people, they have the right to make unwise decisions. They have the mental capacity to be able to do that. And so risk may remain. And it may be that that as a result of that risk remaining, we may need to ensure that we keep an overarching view on how somebody is supported in the community to enable that risk to be managed in an ongoing way. Does that help?
Okay,
Yeah,
well,
thank you.
I'm
I've got
keen
no
to
more
move
questions.
on, but we will have a think about how we might be able to split, if we could see how we can split that data down, because notwithstanding the difficulties, I think the committee would appreciate being able to compare and contrast, however difficult that is and whatever the idiosyncrasies of that are. But perhaps if we have a think about how we might be able to do that going forward, I think that might help. Okay. Right, I'm going to move on, if I may then please, to item 7, which is the annual adult social care complaints report, and to ask Nikki if you would lead us off on that, please.
Thank you very much,
sure.
Chair.
Sure, thank you, Chair. So my name is Nikki Mitchell. I'm the Head of Transformation Integration for BCP Council Adult Social Care. And within my service area sits our statutory complaints process. I've got a presentation which summarises some of the key points of the report. I'm struggling with my my technology tonight, so Debbie has come along with me. Debbie is our quality assurance team manager who manages the complaint service on a day-to-day, so she's going to share the presentation for me. And if I get kicked out of the call, she will carry on with the presentation, but fingers crossed, technology will work on my side. So yeah, first slide then, Debbie, please. Doesn't seem to be moving on. Lovely, thank you. So just very briefly then, to the purpose of this presentation, so I'm going to be talking about complaints in general, how that's governed by our some statutory regulations, talk a bit about the complexity of complaints because that's a growing issue, show you some key learning examples, also talk about our compliments, which is really important to remember that we get a lot of compliments, and also then how that fits in with our quality assurance framework. Next slide, Debbie, thank you. So hopefully from the report, you'll remember that this reporting year we had 196 complaints. That was compared to 172 in the previous year, and that's out of 5,000 adults and 4,000 carers. So we're kind of up to numbers now we were pre-COVID. The last couple of reporting years, our complaints numbers dropped. Particularly during the COVID time, they dropped quite substantially. We're now back up to the sort of numbers we were receiving before that. And that's a national picture as well. Most other local authorities are experiencing that. We also field a total of 135 individual concerns and general inquiries. So we'll quite often get someone contacting us that they want to deal with something outside of the complaints process, or they want to make an inquiry about how things might should be working and so on. So yeah, quite a small team, but a busy team with lots of support being offered to people so we can improve their situations for them. We also had 45 representations this year. So representations are where someone might make a complaint about a central government policy, for example, or one of our policies that is a statutory process, something we can't change. So it's not a complaint of something for us to investigate as such, but it is a representation that they don't agree with whatever it might be. That's risen dramatically this last year. A lot of those come from MP inquiries. And yeah, we had 19 the previous reporting year, so we're keeping a close eye on that as to why that might be. Ombudsman's complaints. So we are governed by the local government and social care ombudsman, so when a complaint has been through our local statutory complaints process, if the person remains unhappy with the resolution, then they can make a referral to the local government social care ombudsman, and they can expect an independent review. So this year we had 4 of those referrals that were investigated, as opposed to 9 the previous year. It's important to say, though, that we actually had 14 complainants go to the Ombudsman, but the Ombudsman said that they weren't going to look at 10 of those referrals because they felt that the council had done everything it could to rectify the situation, and they didn't think that a further investigation from them would change the outcome. And I think that's owed to the fact that we have worked really hard over the last couple of years with our responding managers, with our complaints team, to give really robust complaints responses and really work with people at a local level to understand the situation and put things right where we can and learn from our complaints as well. And that just goes to show that the Ombudsman reported in their annual adult social care complaints report that the upheld number for complaints this year was 75%, where we stood at 25%. So we had 2 upheld, 1 was upheld, and we are still awaiting 6 decisions because, unfortunately, the Ombudsman, and rightly so, when it's complex, they take quite a long time to get through their investigations. So complaints roll over from year to year. So that makes it quite tricky in terms of reporting. But yeah, we always include last year's decisions that weren't in last year's report in this one. So I hope that makes sense. Moving on then, Debbie, thank you. So just wanted to give you our top 4 themes, complaint themes. In the complaints report, you'll see all of the themes. So communication and perceived standard of service and professional practice was in the top 4. So is finance and charging. Decisions around assessment and eligibility, and that's kind of been a growing theme over the last few years. Obviously, as our eligibility has got more, what am I trying to say? As you know, we've had to tighten our eligibility, and people are kind of challenging those questions, those results of those assessments more. And a new one over the last year was delays in providing a service were on the increase. I'm pleased to say this year, which in this financial year, those complaints are now dropping because we've done an awful lot of work to manage our waiting lists and to increase the provision of things like domiciliary care, which allows us to put in packages of care quicker. Also really important there to remember compliments. So we had 196 complaints, but we also received 191 compliments or messages of thanks and appreciation. And sometimes it's easy to forget about all the good stuff we do as well. So we really focus on our compliments too, because they can give us learning, and I'll talk about that in a little while. Yeah, just wanted to touch really on the complexity of complaints. Complaints are growing in complexity. So we've got a regional complaints managers group, and this is a picture across the region and nationally. Complainants need more support to understand and follow the statutory process. We have 18 people this reporting year that made more than 1 complaint, and additionally other complaints required further support to prevent the process from becoming protracted. And what I mean by that is unfortunately, it's hard sometimes for people to accept the council's position or maybe even the ombudsman's position. And so they will continue to challenge us. But the statutory guidance says that we can only answer a complaint once it's been through our process and we've had the opportunity to give our position and investigate and put things right where needed and learn from it. Then the next stage is the ombudsman. But sometimes it's hard to support people with that understanding. So we do have an unreasonably persistent complaints process, which kind of sets out, you know, if someone is meets the criteria for unreasonably persistent complaint, that, you know, that they keep coming back to us and it's taken up a disproportionate amount of our time to manage that, those complaints, then we do use this UPC, we call it complaints process, to manage that contact, along with communication plans where we agree single points of contact for people, so we can clearly manage people's expectations. And so people, when they are challenging us, they have a single point of contact, so they can build that relationship with an officer and hopefully improve that relationship and help with that understanding. Next one, please, Debbie. I just wanted to talk about some key points of learning. There is a table in the report, the appendix, but these are just 3 things that I picked out for you, just to give you an example of some of the things that we do learn from our complaints. So the first one there I've chosen is we had a complaint around eligibility for the Preparing Adulthood team and the letter that they received as a consequence of that. So the complaint was around the letter and the information that was contained. So we reviewed those letters within the team. We adjusted the wording and amended it so it was more clear and there was more clarity around the decisions that were made and the eligibility for those young people and their families. We also had a complaint that was referred to the Ombudsman around consistency of service for when a member of staff was absent, so the person's allocated practitioner unfortunately was off poorly, and there was a visit missed, and there was a complaint around the service that they received during that time of absence. So the Ombudsman recommended that we reviewed our process, which we did, and we put in some new guidance around how caseloads should be managed when staff are absent. How we then make sure we put out of offices on, and that we make sure that if there's a visit due, that either someone else goes or we very clearly message and talk to the person so they understand why they might not be getting their visit and so on. So there's a new process in place around that. Important here to say that this is a really good piece of learning, because we did have 2 similar complaints at the time, and when the second one went to the Ombudsman, we were able to say, we're really sorry, we've learned from this, we have put in this guidance, and we're really trying hard to be a continually learning organisation. And the Ombudsman accepted that, and they appreciated the work that we'd done, and they didn't investigate the second complaint. There was a complaint received regarding communication in the contact centre. So again, there was a new process for logging voicemails and making sure we respond to messages. That was developed, and calls are also now recorded, and these are reviewed during officer supervisions, so we can make sure that quality of contact and communication is where it should be. Thank you, Debbie. So yeah, going on to compliments then. So themes from compliments this reporting year. You can see there, I won't read them all out, but we've had some really lovely compliments about people's professional practice and their manner. Better outcomes for people is really good. It's really great to hear when someone says, one example I always remember, someone's mum was hesitant to go into a residential home, but the social worker worked with the family, worked with the mum, and they managed to come to an agreement, and the mum did go into the residential home, and then she flourished and was able to have her independence, and rather than worrying about falling at home, etc. And the family and the mum wrote to the social worker and said, thank you so much for taking the time to explain the benefits of this to us, and we're really glad that we made this decision in the end. So it's a really good outcome for the family and for the person. So next slide, Debbie. So how we use that intelligence from compliments to learn. So when we receive compliments, we make further inquiries with the colleagues that receive them, and their managers to identify why that might have happened, why they've made a positive difference to someone, so we can share that good practice. We do get some practitioners that get 5, 6, 7 compliments a year, so we go back to them and look at what it is that they're doing, why they might be receiving all of those compliments. We encourage managers to nominate colleagues for our stars, which is, I don't know if you're aware, that the council sort of award, staff award recognition initiative, so we can celebrate our work across the council as well. We share good news stories and compliments in staff newsletters, and we've also got what we call stories of difference, which are records where a practitioner will say exactly like that outcome that I've just explained, you know, that we did this piece of work with someone and this was the outcome for them. And we also have our journey documents, which are like case studies, so where we've made improvements to a process or a working situation that's made outcomes better for people. We'll record them on our journey documents, and we celebrate these. We've got them all on the SharePoint site now, and there's a library so staff can refer to them. And the principal social worker and the principal occupational therapist, they host learning webinars and practice briefings. So we have something called The Good Stuff, where it's a half-an-hour webinar every month, and we'll talk about compliments and stories of difference as well. It's a really nice half an hour for people to come along to and listen to all the good work that goes on. Next one, Debbie, please. So just the last slide here then about the quality improvement framework. So just wanted you to understand how this all feeds into our quality improvement work. So the findings in the report that you've got feed into our recently reviewed adult social care quality improvement framework, which is very much about identifying improvements, looking at our compliments or our complaints, learning, triangulating that perhaps with an audit that we might have done, with any performance data that's relevant, so we can see the bigger picture and get some really rich information as to what might need improving or what we might want to look at. So that's what I mean there by we triangulate it performance data. We've developed the Executive Performance and Quality Improvement Board, and underneath that we've also got an officer-led Quality Improvement Board where we look at these pieces of improvement bits of work that we've identified, and then we've got that governance around it that ensures that any learning that we say that we're going to put in place or any improvements that we are going to put in place, that we've got that governance and that accountability to make sure that it happens and that it is making better outcomes for people. And we can also use it as evidence for the upcoming CQC regulations framework inspections that are imminent as well. So I think that's the end. Yeah. So any questions? Sorry, I rattled through that. I hope it wasn't too quick.
Okay, thank you very much indeed for that report. Can I just ask on the Executive Performance and Quality Improvement Board? Yeah. I don't expect you to reel this off the top of your head, but would you be able to let us know exactly what data it is and what performance indicators you're looking at?
Yeah, sure. It's a combination of performance data and quality assurance data. We've in terms of performance and data, we've developed a core data set. So our corporate data and analytics team retrieve that data for us from our management information system, and then performance comes under my area as well as quality and complaints. And so the performance team then put that into a narrative that we can use then to understand how we're performing, and we have that oversight and governance of it. So I can definitely share that. I can, yeah. It's probably too much to go into right now, but certainly it's something that we can share. We can point you in that direction.
That'd be great.
Yeah.
Sorry, are there any other questions, please? Councillor Dedman.
Yes, thanks, Chairman. Not a question, really. I just think that they've done jolly well this year. And I would also say, as a matter of empirical knowledge, that people are complaining a lot more about things because they don't understand what they're entitled to and what they're not entitled to, or very much very more often what their mother is entitled to or not entitled to. And I think that's the only bit of communication that needs tightening up, because I think we councillors try to explain. I get a lot of stuff in my mailbag, you know, about, well, why haven't I got it? Somebody up the road has got it. And it's very difficult to explain. So I think you're doing jolly well. Thank you.
I think, Betty, you could.
Yeah, thank you, Chair. It's just to reiterate that we can get the core data set to members. I can do that via Louise, but I would just be cautious that what we will share may not yet be in the public domain, because we're working our way through some of that information. So just wanted to kind of state that. Thank you.
Thank you very much. Then we'll move on to
Thank you.
item 8 on update on NHS dentistry provision. But before that, I hope you'll have spotted the deliberate mistake that I didn't ask you to formally accept the recommendation on item 6 on the Safeguarding Adults Board. Everybody content to accept the recommendation? And similarly, on the last item on the annual adult social care complaints report, everybody content that we accept the recommendation on that? Thank you. That was my oversight. Okay, we'll move on then to the NHS dentistry provision and invite Rob Payne and Louise Bates. I don't know who's going to go first, but we're over to you.
Okay, thank you, Chair. I know Louise is online. Louise, are you happy if Matt and I go first and you come in after? Is that okay? Chair, thank you for letting us come together to present, because we thought it's really important to show how we're trying to work together around this area of work. So thank you. You would have received a report, Chair, to the committee. I just want to share some slides with you this morning, this evening, to give some background before we move on to my colleague Matt Baker and then on to Louise. And then, as I say, hopefully we can have a discussion around these areas as well with you. The first point to make is that NHS Dorset Integrated Care Board took on responsibility from NHS England from April this year for high street dentistry alongside pharmacy and Optom services. And we work jointly across the NHS South West as part of what's called managed clinical networks to manage a lot of these service areas. And locally, we work jointly with partners across the integrated care system, including Healthwatch. I think the other point I just want to make right up front is that dental access and oral health is a significant challenge for us locally across Dorset, but also across South West and also nationally as well. So we're not alone in having some real challenges around this area. So it's a really important topic for us to consider with you this evening. So as an integrated care system, as I say, we've taken on delegation of responsibility now across the 4 primary care contractor groups: general practice, pharmacy, Optom and dental. We feel that these are really important high street services, and we're really keen to support these contract holders to work with us around supporting our ambitions around integrated care provision in local communities. And really importantly, I think we need to work with these groups around looking at the sustainability of their services currently and how we can work with them to transform services to meet population needs moving forward. And as I say, we also do this as part of joint working across the southwest of England, and really importantly in terms of sharing the expertise that exists across the southwest, and particularly working with our clinical networks across that area as well. When we work with these contractor groups, we're really focusing on our core purposes of the integrated care system, particularly to look at population need, to try to tackle inequalities, but also as well making sure we're trying to get best value for the NHS pound and for the integrated care system pound, and also as well recognising that these are really important employers locally and contribute to economic development, and also have a wider role in working with us around community health and wellbeing. It's really important as well just to flag up that although we want to talk to you about dental access this evening, we're really keen as well to focus on oral health moving forward, and particularly addressing the determinants of oral health inequality. The Chief Dental Officer earlier this year just reminded us all around the wider determinants of health and the impact that that has on oral health. And obviously there's a key link here between oral health and the need for dentistry to meet our population needs. So as part of this work, we're really keen to work as a whole system with public, patients, partners and care professionals to look at how we move forward. And within this, we're really keen as well to have a focus on reducing healthcare inequalities, particularly for children and young people. And some work we've started since we've taken on the delegated responsibilities to look at the significant backlog for children waiting for tooth extractions, working with our community dental services and our hospital service providers as well. There's currently over 700 children waiting for procedures, and we are targeting to reduce those waits significantly and try to improve oral health, which will directly impact on addressing health inequality for those children and young people. So within that focus on under 18s as well, we're also looking particularly around supervised toothbrushing, and we've just commissioned work locally which will benefit all those children in their early years around supporting good oral health. And we're particularly focusing locally on how we can make dental practice more child friendly and child focused. And we are one of those 7 Southwest pilot areas through a dental practice in the Corfe Mullen area. We're also really keen to work on some of those target population need groups. So there's another dentist in the Poole area that's working with us about looking at how we can address the needs of looked after children. So really in some, before I pass to Matt, just to give us a bit more of the data background before we pass to Louise. Dental access and oral health is a very high priority for us in Dorset. But I think it's also fair to say that it is a high risk in terms of the sustainability of services and how we need to transform services moving forward to meet population need and secure those services to meet both the local needs, but also linking this into that wider determinants of health work that we need to do as an integrated care system. It's a great opportunity for us though as integrated care board and integrated care system to really take on these responsibilities locally and try to make the difference on our oral health and dental access. And we are also working, as I said, in collaboration with partners across the Southwest to do this work. We've got 3 key areas of work around our dental reform, as I said, around oral health, but also recognising that the future is to look at that dental workforce, not only the dentist, but the skill mix of that workforce, and work with dentists about the model of care and the sustainability of that business model as well, recognising that dentists work in both NHS and private practice. And we're all only too aware of the significant challenges around dental access. And Matt's going to say a little bit more about that, and then Louise will be able to share with us some findings of the Health Watch report on this. Thank you.
Thanks, Robert. Next slide, please. So just a bit of information around the services that we've got in Dorset, some of the numbers and some of the commission services that we've got locally. So just as a bit of an overview, you can see that we've got dental provision in what we essentially say three settings. We've got our primary care colleagues, which what we all recognise as our high street dentistry. We've got secondary care dental services. These are maxillofacial and dental concerns that come in largely via our emergency departments. And we've got our community services, which is services for those with additional needs, and also services, as Rob mentioned earlier, for children requiring general anaesthetic and more intensive procedures. A lot of the information that are produced here is primarily looking at our colleagues within high street dentistry. But just as a reminder, and many of you will know this already, that our NHS High Street colleagues are independent businesses, very much like our GP colleagues, operating under NHS contracts. Many of these obviously also offer private dentistry as well. All contract holders employ their own staff, so they're not NHS employees. And they provide their own premises, and some of those premises costs are reimbursed. It does include some domiciliary treatment, and the currency we use, and I will refer to this on a number of occasions, the currency that's utilised within dentistry is units of dental activity, or UDAs. Next slide. I won't go through this slide in detail, but many of you that do access high street dentistry under the NHS, there's various courses of treatment that's available under NHS terms and conditions, and you'll see each of those treatments relates to a unit of dental activity. So very basic checkup will link to one unit of dental activity, whereas work around crowns and dentures and bridges, quite complex work, will be 12 units of dental activity. Next slide, please. So some of the data that we've got, just to say here, is that the data is the County of Dorset that we've got here. And dental practices do not operate boundary or lists like we recognise within our general practice colleagues. So when I'm saying Dorset, it's for both Dorset Council area and the BCP Council area. So we currently have 121 contracts in Dorset delivering units of dental activity. 109 of these are colleagues within high street settings or primary care settings. And we commission around £40 million worth of NHS dentistry in Dorset. Next slide, please. This slide gives an indication on the levels of contracted activity commissioned across Dorset. You'll see that we've had, particularly after the pandemic, that we've had a period of under contracted activity, and currently in Dorset we're looking to target 66% of contracted target by March 24, so still significantly below what we had pre-pandemic. And with our orthodontic contracts, which is a mix of high street and hospital activity, we are estimating to be over target by March 2024. So in terms of setting the scene, what it means in terms of our members of the public accessing dentistry, you'll see there that in June 21 and in June 22, we've seen a decrease in adults accessing dentistry. And just a point here, that the percentages that we see on this slide are adults who've seen a dentist in the previous 24 months. And just to make it complicated, the percentages for children are those who've seen a dentist in the previous 12 months. It's how the data is collected nationally is why that's slightly different. As you can see, that in Dorset, we are just above the Southwest average and just below England. And for children, access is the same as Southwest and just below the England levels. Next slide, please. In terms of what that means for our population in the County of Dorset, the latest data that we've got, which is June 23, shows that 41% of the adult population in Dorset have seen a dentist in the past 24 months, and 53% of children have seen a dentist in the past 12 months. Just a bit of context on the reform programme we've got. Rob mentions that we're obviously working very closely with our colleagues within the Southwest. The dental reform programme was set up in 2020 post-pandemic. It's a mixture of stakeholders, commissioners who have overall responsibility for oral health commission in the Southwest, and the strategy it was essentially put together to inform how we look at overall improvement in oral health for people living in the southwest of England, and obviously those in Dorset. And much of the work is underpinned by our oral health needs assessment, which is delivered via the Health and Wellbeing Board, and the last OHNA or Health Needs Assessment was in February 2021. There is a national and regional plan to recover NHS dental services to pre-pandemic levels, and that was established in the autumn of 22. As Rob, next slide please, sorry Rob. As Rob alluded to earlier, there are a number of high risks and challenges within the dentistry profession. Workforce, a bit like other colleagues and across other primary care settings, workforce is a real challenge. We do not have a dental school in Dorset, and one of the statistics that we've been recently given is that 50% of dental professionals reside within the M25 boundary, which is a real challenge for those outside of their settings. Our nearest dental schools are in Portsmouth and in Bristol. Obviously, post-COVID recovery has been challenging, very much like much of services within NHS. We have seen a slight increase this year on the latest data, which is encouraging, but we're nowhere near the levels that we had pre-pandemic. We need to increase need for those who haven't had access to primary care, and I'll touch on that on the next slide. And there's also, as Rob alluded to earlier, the sustainability of the dental practice business model. Bit like we've all seen, there's rising cost of living, the additional increase in business costs, and of course attracting good quality dental professionals to the area is very difficult and challenging. As I alluded to earlier, we've had significant underperformance in the dental field. The contracts are funded at 100%, and many of you may understand that there is a patient charge for those accessing NHS dental services, which is recuperated back into the NHS purse. Underperformance in all practices, there is a clawback, so dental practices only get paid for what they deliver, and any unknown activity is often commissioned for non-recurrent services. So where we have performers that can increase their NHS activity, we can move some of that funding between contractors within year. One of the really challenging areas that we face, and this is the national NHS contract, is that the unit of dental activity value is historical. Within general practice, all GPs receive the same funding for patients that are registered with them. For dentists, the UDA value is not fixed, so two dentists next door to each other could actually be receiving different funding for the patients registered at their practice. Just before we move on to kind of our plan for the next couple of years, I just wanted to touch on one of the other key areas of work that we've got, and it is related to urgent access. We've seen post-pandemic a real increase in patients accessing urgent care dentistry, essentially because they've not been to the dentist in a very long time. One of the areas we're working with our colleagues in the Southwest is a program of what we call stabilisation. So these are for members of the public who are repeatedly seeking urgent dentistry, pain relief, accessing 111, 999 urgent care services. So what we have agreed with other colleagues in the Southwest and for us in Dorset, that we are increasing the levels of stabilisation sessions across the county. So this is essentially to stabilise individuals' oral health, which will mean reduced pain, reduced likelihood of going in and out of urgent care settings, and less prescribing of drugs. It's a much more permanent solution for patients and better outcomes, and for the NHS purse. Rob, just for us, final slide, thanks.
So thank you, Chair. Before we hand to Louise, just by way of summary then, we're working closely with public health colleagues, with Jane Horn, who leads for oral health across Dorset. And we're particularly keen within the next year to complete some epidemiology studies, which will give us much more up-to-date data on oral health needs across Dorset. Alongside that, working again with public health and colleagues across Dorset on oral health promotion, which we'll see going into the early years setting within the next year, and then the child-friendly work as well. As Matt and I have said, there's significant challenges around the dental workforce, but also we want to support the dental clinical leadership and the way in which the dentists in Dorset can have a stronger voice in our system, working with other colleagues about the future of dentistry and how we develop that. We're in very early talks around, could we attract some dental school provision in the Dorset area moving forward, but we're also looking at the existing workforce about different models of employment of dentists, for example, salaried dentists, and also looking at schemes such as dental fellows, where we could bring in some specialists to focus on particular population health needs in different areas of Dorset, which could include areas of deprivation, children's health, older people's health, etc. And we're also, as I said earlier, focusing on work around dental access, not only the high street, but also looking at children with complex needs. And as Matt said, that really important pathway through urgent care into stabilisation to provide a much better package of care for those with urgent care needs. So that's an overall summary from us. And if it's okay, Chair, I'm hoping we can pass to Louise to give us an update on the Health Watch component of this.
Yeah, just before I take Louise, looking around the room, I've got a little bit of surprise by the fact that two dentists adjacent to each other might actually get paid differently. And I heard you say it was historical. I mean, is anything being done to change that?
Yeah, so this
is it, above your pay grade or something?
This is a really long-standing national issue, so we're not going to be able to change it overnight, but we're in talks around it. And what we want to do is we want to look at the UDA rates across Dorset and how we might adjust those to, reduce that sort of inequality of access to those funding, but also as part of that to have a conversation with our dentists around where there may be a need to put more funding for more complex work. So if a dentist is working with a particularly difficult population in terms of the challenging oral health need or deprivation or other complex needs, and I mentioned earlier, for example, looked after children, we may well want to agree that they do have some additional funding to meet those more complex needs. So yes, we are in discussions about that, but as you say, we're also concerned about that.
If I add, I spoke about underperforming dentists, and when I say underperforming, they're not meeting their contractual obligation for the NHS. They only get paid for what they undertake. What we've recognised is many of the dentists that are underperforming are in our areas of deprivation in the county. So particularly in parts of BCP and and in Dorset, in Weymouth and Portland, for example. So what we want to do as part of our place-based work and working with our neighbourhoods is actually what can we do with those dentists in those areas? Have those conversations. Is there alternative provision? We want this money to stay within dentistry. We don't want to lose that the funding. So it's how can we commission services differently? And I think that's the benefits of having pharmacy, optom and dental under local commissioning is that we can drive some of those more local conversations, particularly in rural areas of deprivation, those with high demand for children's services.
Okay, thank you very much. Sorry to keep you waiting, Louise. Thank you very much if you're ready.
No problem. Thank you, Chair. I'll see if I can share. I've just got a couple of slides. see if that will work. Can everybody see that? Great. It looks a bit small for me. Does it look small for you? I'm not sure how to make it larger. Can everyone read it all right? Yeah, okay. So as you all know, HealthWatch is the independent champion for health and social care, and we find out what people think about local health and care services. So around 2,000 people spoke to us last year, and the number one issue that people contact us about is access to NHS dentistry, which I'm sure won't come as any surprise to you, because I'm sure as councillors you're hearing from your constituents all the time as well about people trying to find a dentist. So we've published a couple of reports in the last couple of years about what people have been telling us about access to dentistry. And you can find those, there's a link on this slide to them on our website, and I'll share this with you afterwards so you can have a look at those reports if you're interested. We did some specific work around looking at health inequalities. So we did some work with people experiencing homelessness about access, but as well, more broadly, about what people are telling us about trying to find a dentist. And this year we've been focusing on trying to gather some more feedback to support NHS Dorset, really, to so that the funding goes where there's real need locally. So we met with some voluntary sector groups who support people who are particularly vulnerable. We met with oral health educators, parent carers, dentists, public health and local people, try and find out a bit more and dig a bit deeper into what's going on locally. And that's a quote which is a fairly standard kind of bit of feedback that we'll get, where people are trying to access a dentist because they need a sign off to get treatment for cancer. And if people are unable to find a dentist, they can't continue with their treatment, which is really worrying. So we're working with NHS Dorset this year to make sure that all that feedback that we're hearing from local people really makes a difference to the way services are commissioned and provided locally. So by sharing people's experiences, we're helping the system direct funding where it's most needed. So thinking about that stabilisation pathway that Rob and Matt were talking about, and make sure that people have good access to that and people get support to go along and use those appointments so they get used in the best way. We are working with public health as well to look at how to distribute some oral health packs in the community, particularly in food banks, and working with some minority groups as well to make sure those oral health packs are really getting out to the people who need them. And then encouraging clearer information as well about access, because I think somebody was saying earlier about how difficult it is when people don't know where to go, and this quote's like a standard thing that we're hearing all the time, where people are ringing around, calling dentists. There's no information out there to know how to go about trying to access a dentist, and so some clear information would be really helpful. And there's just some contact details for us, so I'll share these slides with you afterwards. Does anybody have any questions? See if I can stop sharing.
Any questions, anybody? Oh, that's wrong.
Sorry, I'm at a distance, that's why I'm stepping forward. I have two questions. My first one is, has there been a shift from people not being able to afford to pay private dental because of the cost of living, and is that causing an additional pressure? And my second question is, so oral health has always been very private and a lot less NHS, but the knock-on effect is the acute coming through the door with dental problems that could have been prevented with being able to access dentists. So I'd just like to know, or challenge, what can you do differently around commissioning if you have a reduction in activity? And I recently had an eye appointment at a check in Christchurch, and I was very impressed with the fact that I could just go to my high street and go and have my eye appointment, which I would have gone to the hospital for otherwise. And I know that's a very sort of simple example, and I know you need the staff, and if you can't recruit, I'm totally with you on recruiting. I had someone that I thought I'd recruited, and they sent me an email today, which was very depressing. So I know how hard it is to recruit NHS staff. But my challenge is, you know, you talked about your ideas around commissioning. Is there some really clever, slightly thinking out of the box ways that you could actually offer something a little bit more high streety than it's not the traditional dental practice? Thank you.
I'll take another question as well. Would you prefer to answer that one first?
Happy to say that one first, Chair, if that's okay. Yeah. Before I answer it though, can I just make a really important point that I haven't made this evening is when we speak to dentists, they endorse it. They remain passionate about working for the NHS. I haven't made that point. I really do need to make that point. And also they're passionate about the health, you know, meeting the health needs of their population. And I say that because we've only got to look to the media, you know, all over the country about, you know, the state of NHS dentistry. And I think the dentists, and I've seen, you know, really upset dentists, and it's affecting their mental health as well about, you know, the challenging meeting the population needs. And that's why I made the point earlier as well about the importance around oral health, because if we don't tackle the oral health long term, then we're never really going to, you know, meet the challenge around access to dental care. So I want to make that point up front. So we've only taken on the delegation from April, so we are still early, but we are really ambitious about how we transform things over the next, you know, months and years. The government are in discussions with our dentists about, you know, the dental reform and particularly the dental contract. Our dentists will say locally that the contract is not fit for purpose, so they want to see a completely different contract. What the government have introduced very recently is something called flexible commissioning. So they are giving us more powers now to flex those commissioning locally. So that's really good news. And so we're in discussions now with our dentists locally about how we can commission in different ways. One thing relates to what Matt was saying earlier about, you know, for years now we've commissioned based on units of dental activity. And what the dentists want us to do and what we want to do is actually look at different ways to commission them. And some of that is like a sort of sessional fee. So the dentist agrees to provide a service on a sessional basis. The challenge there, of course, is to make sure that we're still getting value for money and we're still trying to keep those access levels up, because the budget for NHS dentistry is also really, really limited. I think people are shocked to hear that nationally the agreed funding for NHS dental care is 50% of the population need. That's how it's been set for a number of years now. So there's a real challenge around meeting the needs. And so you can see why that's driven a need to try to increase the units of dental activity as a proxy measure of access. But what we're hearing from our dentists is, you know, that's just not working. That's not a sustainable model. And they want to work with us about a more sustainable model, but a more targeted model around meeting the population needs. So we are in discussions with them around a much greater flexibility locally around how we commission their services moving forward.
Thank you. I've got a number of other questions, so I'm going to take them in the order that I've written down. Councillor Salmon.
So I'm just curious, I might have missed it in the report, but I still don't think we've identified the scale of the problem in terms of how many patients are seeking NHS dentists but can't obtain them, and how many of those people who are accessing the emergency dental service are doing so not because they've got an unexpected emergency, but because they don't have access to dental provision, be it NHS or private. And I also think it sounds like we can only talk about tinkering around the edges. The root cause is level of funding and the existing dental contracts that exist that are set up. Like, I've got an NHS dentist and they've been very clear they cannot, under the NHS, do the work that I need done. All they can do is rip out a tooth. So they've said, look, wait until it gets bad, call us back, we'll rip your tooth out. Otherwise, you've got to go private. And I can't bring myself to do that. I wouldn't use private healthcare at any point. I might have misheard Councillor Allen, but she said dental's always had some level of private provision. I don't think that's the case any more than GP provision has always been private in the NHS. I remember growing up with an NHS dentist when that was the only option. Private provision was something that was introduced in my lifetime. And I just wonder what work is going on and coordination's going on to actually properly address that, because the dental provision is the area of healthcare where we've got the biggest problem with parasitic private provision of care. And until we address that, we're not going to be able to provide effective public healthcare when it comes to dentistry. So yeah, scale of the problem and what work's being done to scale back the amount of private provision and how much it's encroached on proper public provision.
Okay, number of complex questions there, but I mean, I'll try to at least touch on some of them. In terms of the understanding of the information and the data and everything else, you know, I think it's important for us to understand at this stage, at least, our sort of business intelligence around the NHS dental contract does rely on the data, as Matt said, that is extracted through dental contract returns, and we get business intelligence support as part of that Southwest collaboration. But any questions that are raised here, that you know, we can take them away and try to find out more information in those areas. As I said, you know, we're really keen to progress the work locally around oral health and understanding the epidemiology, working with public health colleagues. So that is something that we are commissioning this year to understand further. In terms of understanding that need and unmet need, I think that is very complex. I mean, we can start looking at that through the work that we do, and epidemiology studies is part of that. I think the data that's collected is only around patients accessing NHS dentistry. We have no data or intelligence about public accessing private dentistry. Now, if we're going to truly get a picture around access to dental care, we need to understand both.
Right, Rob, just to check then, there's going to be no scope for us in the next 6 months to go, actually 20% of the population in BCP or so many thousands of people don't have access to public or private dentistry. That's something that data couldn't be collected because we miss the private sector figures and they can't be collected.
We can't get access to that private dental access information. What we can do, and it's a reasonable challenge, is, you know, what more can we understand around the public NHS demand on services and drill in a bit more. And we want to get the not just the quantitative but the qualitative side of this as well. So it's really important to work with Louise and others around that sort of, you know, patient experience as well. We are in conversations with our colleagues in communications engagement as well. Members of this committee may be aware that over the last 3 years we've built up patient participation groups in general practice. There's no similar arrangement in dentistry, but we are in early talks with Compton Engagement and Louise and others about, can we look at a way to engage patients and public in a more proactive way, really about understanding, as Louise said, we've done some of those studies, but how can we do that in an ongoing way to get patients and public working with us about understanding what's going on in dentistry as well, because that patient and public voice is really important as part of the work that we're doing as well. Thanks.
Okay, I've got a list of people that want to ask questions. Going to take Councillor Carl-Brown, Councillor Adams and Councillor Matthews, please.
Thank you, Chair. I'm going to try and get to the question quickly, but so it's interesting that sorry, it's quite off-putting having that right next to me. You're talking about like patient participation groups and things like that, and it feels that mirroring the GP model actually could be quite a powerful way forwards. The other thing that occurred to me is you have many more salary GPs now than you used to have. That's a model that's really catching on. So that could be a good way forward. And I know that perhaps dentists might like a capitation model of funding as well. But hey, if they're all going to sit in the private sector, then they can keep wishing, I would imagine. So it's quite alarming in a way that we can't get private sector data. Are you saying can't or don't have?
I think it's currently can't. I'm going up to the British Dental Association invited me up as a representative of Dorset on Friday. So we're going to have some of these discussions then. Interestingly, that capitation model is still on the table.
Well, they'd need to make some very good offers in return, I would imagine, for actually staying within the NHS. But without that private sector data, we're really hamstrung, aren't we? Because I mean, I don't know anyone who's got an NHS dentist anymore. My dental surgery just took my children off who've got the right to an NHS dentist, and they've just been, oh, we don't care that you've got the right to it. You're just not going to have it. It's outrageous. It's utterly indefensible. So, to get to my the 2/3 of underperformance. So there's some money somewhere that hasn't been spent, and I can see from your budgets that that money does get, as it were, replaced into the budget. The budget hasn't gone down, so that's good. But you've actually got some spare money, because you haven't spent 1/3 of last year's budget, or you won't spend 1/3 of this year's budget. So where does that money go? And can we use that to incentivize people to come to the area? I don't know, golden handshakes or whatever it might be. I know I'm wishing on a star. And finally, the other thing was, has the stabilisation programme or the stabilisation, has that begun? Yes, and sorry, and just generally, this is a general overarching thing that I'm very interested in, is how much input do we as a council have in what you're doing? How much interface is there between us? Thank you. Sorry about all that.
Well, I'll talk about the underperformance and investment. So there's, as reiterated in our presentation, the underperformance is based on a risk, because you essentially won't get the final figures until the end of the year. So dentists report on a monthly basis what patients they've seen under the UDA, and they report back. So what happens is that there's a 6-monthly review that's undertaken, and you kind of base it on what that performance is then. So there are a number of areas that we've worked with our NHS England colleagues around that funding going elsewhere. Child-friendly dental practices. We have the supervised toothbrushing scheme. We've got the stabilisation pathway. We have the additional theatre space for the children who require general anaesthetic. We're doing some work around some inequalities around homeless that struggle to access services. There's a number of as our plan we stipulated there. So there is some element of that. So you are correct. There is some underperformance, and which means underutilization of funding. All the funding does get used up, because we then have contractors who can then overperform, but not all of that funding is used. So they're on a cycle of just underperformance and recouping that funding back. But that obviously is risk based, so we will, as an ICB, look at absolutely trying to spend every penny of that, but obviously we're in very early days in terms of our responsibilities for taking this on and working with our communities to make that happen.
Can I pick up one of your other this question about working together? Really keen to work together. I think there's 2 key areas. One's around oral health, and we're already working with your public health colleagues, so that is absolutely fundamental, I think, to understanding that wider sort of population health and encouraging a lot of that interventions around children's health and addressing health inequality. The other area that has been flagged up to us as well, and I think this is a national issue, is about how you encourage people into your area. Now, we shouldn't really have a problem about encouraging people into Dorset, because it's such a beautiful place to live and work. But we can, I think, work together about, how can we attract more. So, as I say, we're in early discussions around a Dorset Dental School. They're very early discussions, but again, we would we very much want to seek the council support with having some of those discussions locally, but also, as I say, what other schemes could attract and retain people in the local area. So I think there are things that we could certainly work together on. Thanks.
Well, I had a few questions, but Councillor Carr-Brown asked one of them much more eloquently than I could have. And on the dental school, just for the record, I think it's an absolutely brilliant idea. But is it an immediate go, or how long would it take to actually feel the benefit of it? Because it's probably, what, 5, 6, 7 years' time, and the problem's almost more now, but I do still think it's brilliant. With the workforce issues, are they more acute locally here in Dorset rather than other areas? And also on the sort of clear information that the Health Watch lady mentioned, what advice would you give to someone, say from West Ham, where I represent, which is one of the most deprived areas in the country, let alone BCP? They'd look on the NHS website like I've just done and found the nearest place to get an appointment as an adult entitled to free dental surgery, Southampton. What's the actual advice you give to them? Do you just say, well, suck it up, or where do they actually turn to? And where there's 10 surgeries in Southampton offering services, is that because they're nearer to the Portsmouth school, or is it because they're nearer to the M25, or is there other reasons or other learning we can take from them where they're doing it quite successfully?
Hey, we could probably be here all night just having a discussion on this one. I mean, it's a great question, but it's a really complex area. The first one is a real challenging conversation that we're starting to have with dentists, is about how can they change their practice in a way that's still safe but increases access. So it was on one of the slides, but we didn't deliberate on it because it's a complex area. So, and it's partly our behaviour as public and partly behaviour of the dentist, I would say, is about how often do we need to be checked. Okay, and there's a huge a variation about how frequently an individual goes to a dentist, and there's also variation in that being needs based, or whether it's custom and practice, come and see me in 6 months, when actually the evidence base may be if you only need routine care, you might not need to be seen for 18 months, 2 years. Okay, so you can do the maths on if you would educate the public but also educate the dentists about working differently together, which is this is why this relationship between dentist and public, as we were reflecting earlier, is really important moving forward. Yeah. The other thing is, as you say, we have got particular areas that, as Matt was saying earlier, are being disadvantaged, and we know that there's a link there between complexity of need in some of our more deprived areas, and one of the areas that you serve there, and that makes it even more challenging for the dentists to be able to manage care under the NHS. So we are in discussions around how we can bring in flexibilities for them to make that model of care work, to try to improve access in the local area. The Southampton bit's a bit more complicated, I think, because speaking to dentists locally, so their contract says that they should keep up to date their publication about being accessible. What they'll say to me is, we can update it one day and then the next day we'll have to close it again. And so that communication with public is really difficult, because as soon as they advertise that they've got space, you can imagine what happens. So what they're really keen to work with us on is saying how they can target local population need rather than just open the list for anybody, because as we know, sometimes that'll lead to people accessing a service that have less needs than somebody else. So it's a complex area of work, but we are trying to work through some of the issues. And we're really keen to think about how we can work differently to particularly target population needs in our most deprived or unequal access of care, which is what I think, part of your question tonight as well. Thanks.
I just wanted to add that one of the other investments we made is that have been increased sessions via the urgent care service. So the route to entry for the urgent care is via the 111 helpline. It's then triaged, and then there are a number of practices across BCP and Dorset that provide the urgent treatment. Many of those individuals will then be put onto the stabilisation pathway to ensure that their urgent requirements are managed and not, you do get that horrible cycle of going through an urgent, getting a prescription and actually managing to get over that. Cheers.
Thank you. Did you want to add, Sarah? I've got another question, but
Yeah, I just want to come in on the dental school because actually, quite right. If you put a dental school and we invested in that, it would take a while before you trained dentists. There's a model in Suffolk, northeast Essex, I think it is, and we actually had a conversation with providers there who are actually doing something similar. They kind of looked at they have the same kind of issues, looked at a dental school and thought, actually, that will take too long. And they've got a pressing need at the moment. So they're introducing a new model, which I think they're rolling out, I think from April, is it Easter? Yeah. But they've set up a community interest company. They're an educator, so a trainer, but actually that wider dental workforce, so hygienists, and they're going to have 10 dental chairs. So, and they're working sort of a hub and spoke model, so partnering with local dentists in the area to try and increase the workforce and think about how they do dentistry in a different way and actually commission in a different way. So they've sort of really thought outside the box. I met with them just recently and I thought, you know what, great what they're doing. And we actually don't need to reinvent the wheel here. If that model works and it's really successful and they're really happy to share with us the process they've got, gone through to set it up, we can learn from that. And if that's something that we can adopt here in Dorset, we're really keen to look at that.
thank you. That's really helpful. That would be really helpful. Councillor Message, thank you for being so patient.
That's fine. Thank you, Chair. Yeah, just listening to the last speaker, I think that actually sounds a really good way forward. Ultimately, dentistry is a mess. It's been a mess for a long time, but it's just getting worse and worse and worse. And it's actually good to hear that you're aware of that. So we're not having to challenge you on that because it is really a fundamental issue. And to me, logically, it's just a no-brainer not to look after people's dentistry. It's an investment. It saves money in the long run, but that's another issue. So we do need to think out of the box. The problem is our residents are suffering. They're suffering now, and we need to do something immediately. I mean, that is the crux of the matter. In terms of the stabilisation process, and I can see the advantages in that to an extent. But it's a bit of a sticking plaster, isn't it? It's not a long-term kind of solution. And I do know of a case, not in Dorset, I have to say, but in Hampshire, of a person who did go, had an abscess, went to be stabilised because they couldn't access an NHS dentist, but were able to go have a stabilisation session. I think they had to travel halfway across Hampshire for that process, but nevertheless were able to have some antibiotics, etc. But this person, quite complex needs, on the autistic spectrum, mental health issues, and so on, and needs to have an extraction. Now, the problem, as the person who did the stabilisation pointed out in this particular case, this is a specialist piece of work, and you ain't going to get that done on the NHS. So they're telling a person who's on the autistic spectrum and has mental health issues, high levels of anxiety, who would need to have some sort of sedation in order for the process to take place, that you're gonna have to go private. And that was, I kid you not, that's a story that I've heard. So it's a cultural change that's needed as well, isn't it? So just wanted to share that with you because it is, it's quite a horrible story, but nevertheless, this is the reality of what people are experiencing out there, and I think we need to hear that. So just wanted to share that.
Yeah, thank you. I mean, just to say from a Dorset perspective, we're very fortunate to have a really good community service for dentistry in BCP and in Dorset for those with additional needs, so particularly those with learning difficulties, mental health, physical needs, access needs. All dentists can refer into the community pathway, and we've got a number of settings that are in place already across the county, and some of those are in hospital settings, particularly when you require general anaesthesia or special access requirements. So we've actually increased the investment for community services this year, and we're looking to work with our providers over the next couple of years to make sure we can keep that community service provision. Some patients will have to travel because we can't have them in every postcode or every area, but we are pleased to say that area of dentistry for Dorset is actually well provisioned at the moment. It really is our high street dentistry that we do need to focus on and look after, and look at commissioning in a different way, look at that outcomes-based commissioning. Not, unfortunately, we're not going to get rid of that national contract. We can certainly put our two pennyworth forward, but we need to think outside the box. We need to be brave, and we need to, commission for outcomes in our communities, not count widgets.
Councillor Dedman.
Yes, thank you. You may have already had the answer to this question before and I've forgotten it, but how long does it take to train as a dentist?
Probably talking to the wrong people. I would imagine it's probably 4 or 5 years.
Well, I think it's probably more like seven or 8 years.
Well, because I was horrified when I went to my dentist, which don't mention to Joe is private. I'm sorry, Joe. But I went to the hygienist first, and I said, this is wonderful. Why aren't you a dentist? She said, oh, she couldn't do the training because it was far too long. It was 6 years, she said, and she would have to fund it. It would be a nightmare. And then she's just taken the job as the hygienist. And I think that must be one of the problems. You're talking about bringing a school here, but who on earth is going to train as a dentist for the NHS when clearly what you're saying is it's not funded properly? So, I mean, and the other question was, Chairman, that isn't really a question, that's just a moan. But the other question was consideration on how the council working in partnership can market Dorset to healthcare professionals. I mean, I've no idea what that means, really.
I think what we're saying is there's probably is still more we can do to try to attract into Dorset. As you say, it's multifactorial, as you say, and Dorset Dental School along the lines that Kate, the discussion we're having about that sort of model of, because it's not only about provision of that, it's actually, it is a marketing thing as well, isn't it? That Dorset's now got this new facility. I mean, I've recently spoken to some newly qualified dentists that, unfortunately, they're working in Dorset at the moment, but they were saying that more needs to be done really to make Dorset attractive, not just as a place, but things like the dental school, things like developing different ways of working, different best practice areas as well within dentistry. So I think it's because and there is a link here, I think, with well-established dental schools as well, is the way in which that then develops, the local provision, the local research and development going on and everything else. So I think it is a bit wider about how we work together to develop the provision within Dorset. But as I was saying to colleagues as well, there may be other ways that we can try to work together to encourage. Housing has been highlighted as a key area as well, as you say. If you've got somebody in training, can they get help with do we look to NHS Wales, which I know are also now investing in and I'm not talking dentistry now, but I know they've done it with other professional groups where they actually look to fund people as undergraduates, but do a deal with them really that then they're expected to work for the NHS in that local area after they're qualified. So there are things that we can look at, but they're not quick fixes, but we can certainly look at those together.
Thank you. I could take Councillor Good, and then I think we need to move on, please.
It's just a very quick one. In preparation for the meeting, I decided to go onto the NHS site to see if there were any NHS dentists, and the ones that if you phone them up, they say that they will only take referrals, obviously from other NHS dentists, or but one of the things which I did find was that a number of them were happy to offer me a place as a private patient, which means the capacity kind of is there. So And that wasn't, I wasn't sort of pushing it's just like literally phoning up 5 or 6 different numbers, but nearly 3/4 of them were happy to offer a private dentistry, which means the capacity is basically there, but it's only being provided in respect of the private provision. I just wonder if there's any way that going forward you could look at even subcontracting out to the private care to some extent, but to say, or any thoughts on that?
We have had some discussions around that. I think there is, in that sort of brave space around the future, is about that public-private mix and how that would operate. Also, we were talking about that sustainable business model. We do need to make a commitment more in the long term, I think, with dentists about a sustainable contract offer, because I've spoken to dentists say, and these are dentists are passionate about provision of NHS care, but have found that actually they just can't make the sums add up. And what we must reflect with you today is, as we've already said, is we've only just taken on responsibility for this, so we're not going to be able to fix it overnight. This has been going on for a decade or more, but I think we would, if we're going to be successful in this, we need to listen to our local dentists. We need to work with them about a sustainable model of NHS provision, and I think that's what's really at the root of your question there is, because at the moment, sadly, a number of them have chosen to go into private practice, partly because it's a sustainable business model, but partly also they say to me that they're able to provide a better quality of care because they're able to get the right level of remuneration and funding into that provision, whereas in the NHS care they feel that there isn't enough resource there, enough funding, for staff. They've, as we all know, everybody's got staff costs going up, but their staff costs have gone up significantly as well, and their business costs and everything else. So we do need to, and it's a difficult one. I know it's a challenge, depending on your sort of beliefs around this, but we've got to believe the NHS dentists who say that they are passionate about delivering NHS care. We've got to work with them to come up with a way forward for them to be able to invest long term in provision of NHS care.
One of the stats I've not included today, and I can't remember off the top, but the BDA look at the amount of dentists that have gone into cosmetic dentistry, moving away from managing health. It's staggering, and that is a real issue, particularly when it comes to the, if they look at the funding that they're going to get via NHS or even private work versus what people are willing to pay for cosmetic, it's eye-watering. So that's another reason that we've got dentists, really good qualified people, that are handing back their NHS contracts and leaving their profession.
Yeah, thank you. That's a sobering thought, isn't it? But I'm keen to move on, but Louise, I don't want to move on without thanking you for your report and just giving you the opportunity to say anything final that you might want to say before we move on to the next item. Don't feel you have to, but I didn't want to neglect.
I guess, I'll carry on sharing with you the kind of feedback that we're getting, if it changes in any way, and the sort of themes that we're picking up. And for all of you as well, if you've got constituents bringing queries to you about dentistry or any other kind of health and care service, then you can always direct them to us. If you don't know how to answer them, please send them our way, because the more data that we collect, better place we are to make a difference with it. Thank you.
Thank you very much indeed. Okay, is everyone content that we accept the recommendation on this item, please? Thank you. So item 9, invitation to Councillor David Brown, the portfolio holder, to give us a bit of an update, please.
Thank you, Chair. And yeah, I always find it interesting and useful to attend these meetings. I've enjoyed the discussions and the presentations we've had so far. I didn't comment on that last one, but actually I find it quite interesting, the discussion of the dentistry. I'm really fortunate. I've had an NHS dentist for many years who sees me every 6 months. Unfortunately, now he knows what I do. He spends more time discussing NHS dentistry policy with me than he does actually checking my teeth. But it could be worse, I think, because I spoke to my brother recently who lives in Norfolk, and he's come off of an NHS list, couldn't get any NHS dentistry in Norfolk. and needed some treatment, couldn't even get a private dentist in Norfolk. He was willing to pay, couldn't get a private dentist, had to travel 80 miles to Cambridgeshire to even be able to access a private dentist so that he could pay them for the treatment he needed. So it's not great in Dorset, but it could be a lot worse, and it's worse in other parts of the country. Just a quick update then on things since the last meeting a couple of months ago. I think I mentioned at the last meeting the range of boards that I was having to attend. I won't bore you with the long list again. Probably the most interesting meeting I've had since the last time I was here was at the end of October. I attended my first integrated care partnership meeting in Dorchester, with the new corporate director as well, was along there. That was really interesting. A lot of partnership bodies from the different agencies and from the NHS in the room, discussing various sort of issues about moving forward and looking at the sort of health priorities across the whole of Dorset and across BCP. It's in the early stages, but it just struck me that actually if we can get it right, working as an integrated care partnership, there's a lot of scope for actually really making a difference and addressing those sort of critical health needs across the whole counties, as long as we can get it right and work the right people sort of working together. So yeah, that was probably my highlight in the last couple of months. It won't surprise you to know that a lot of time has been spent on budget discussion meetings, really quite difficult budget discussion meetings, both with officers and then with cabinet colleagues and corporate directors, to sort of thrash through how we're going to sort of balance the gap in our budget for next year. What has helped with that, actually, officers have been working with the LGA. We've had people from the LGA sort of visit and discuss how we use our resources in adult social care and do comparisons with other authorities across the country and look at sort of the different ways that different councils operate. And they've recently reported back on a sort of financial review of adult social care, and that's been really useful to sort of get that to sort of touch base with people who sort of have national contacts and can sort of help and direct sort of those areas where we're doing well and those areas where we could make more of a difference. So yeah, that's been really useful. But then you do all this work on budgets and you think you're getting there, and then the Treasury announced last Tuesday about the national living wage, which is to be applauded, that the national living wage for people is going up from £10.42 an hour to £11.44 an hour, and I think probably most of us in this room would support the national living wage. The difficult thing with that is that we'd already made provision in the budget, in our own council budget, for some of that, but hadn't anticipated quite the extent that it would increase. And when you work out for each 1p increase in the national living wage, that costs adult social care £122,000. That one increase in the national living wage announced last Tuesday is going to cost this authority over £12 million and adds another £5.5 million to the budget gap. We were talking about 44 million budget gap. It's up to 50 million now because of that announcement last Tuesday. And just to put that in context, I think it's about £12.5 million that will cost adult social care because of the cost of sort of care, domiciliary and home care. A 5%, full 5% council tax increase raises about £12 million for this authority. So the national living wage announcement last Tuesday cost this council more than the full 5% council tax increase that we're permitted to make under current legislation, not to mention other staff pay rises, inflation, pressure on our services, more demand for services. So I think that puts the sort of council's financial position in context when you look at that. A couple of other, well, one main ongoing piece of work to update you on, which I've mentioned previously, is about the day opportunity strategy and the sort of public consultation and a survey coming up for that. And that is due to go live this Friday. That's the latest date I've been given, I understand, on the 1st of December. Looking at the draft day opportunity strategy and potential changes to how our day opportunities are delivered and the day centres that we operate around Christchurch, Bournemouth and Poole. So yeah, we'll be encouraging users and carers and families to respond to that consultation, let us know what their thoughts are about how we're proposing to sort of change people's access to their opportunities and move to a more sort of community-based provision. So that will be something interesting, I think, probably for everybody on this committee to keep an eye on when that's sort of launched later this week. Finally, we are lucky that later this week, Wednesday, Thursday, Friday, the National Children's and Adult Services Conferences at the BIC, organised by the LGA, I think. And so there'll be an awful lot of social workers and portfolio holders and social care related organisations in town for later this week. And what's really pleasing, there's lots of sort of speakers and sessions to attend there, and quite a few officers will be there. What's really pleasing to hear is that one of our own BCP teams will be there speaking on Wednesday about preparing young people and families for adulthood and looking at a collaborative approach. So it's not a case that we're here in BCP doing what we do and trying to learn from what others are doing. We've got teams that are actually doing good things, doing good work that actually other councils could be learning from how we do things. So I think that's to be applauded. I think that's all I've got to update on. If anybody's got any questions or comments.
Thank you. Thank you. Any questions? Councillor Tedman.
No, Chairman, it's not a question, it's a comment. I think care workers are worth far more than the figure you quoted, having been one, employed them and sometimes needed them. So I really applaud that. I know it's a terrific burden on the council, but we need care workers and they need to be paid well.
Are there any questions? Okay, thank you, Councillor Brown. I would just say that thanks to Betty, that the presentation that's going to be made by the BCP team on Wednesday is going to, is that tomorrow? I was just trying to think, is that tomorrow? It's going to be, I'm going to come and do it here as well in the new year. So thank you very much indeed for arranging that. That would be very useful. But thank you all for that. I'm going to move on. I think we've lost David Freeman, have we? Okay, we were going to do a bit of an ICB presentation at the end, but David's had to go, so we might have to find a way of doing that differently. Okay, but can I move on to item 10, which is the task and finish group? You recall that we did discuss this at the last meeting, and I can now advise the committee that a date for the first task and finish group has been set for Monday the 11th of December at 6 p.m, which we're going to do via Teams, just to enable officer participation. This is obviously about data, and the usual practice is that we invite 3 to 4 members of the committee to be party to that group. So really, you can either let me know now if you want to be part of that group, or you can have a think about it and have nightmares about it in your sleep and let me know in the morning. But the first meeting is on the 11th, which is really intended to be a scoping meeting, what's out there already, what we need to dig a little bit deeper on to try and find where there might be that data. But that's the nature of the meeting on the 11th of December.
Yeah, just to say that date isn't very far away. So if you do want to join that working group, if you could contact the chair and copy in Democratic Services as soon as possible, because if there are not enough volunteers from this committee, we can look wider than the committee to other non-executive members. Thanks.
So I shall await floods of volunteers. Joe's looking very calm. Thank you very much.
So Patrick, yeah.
Go on, Joe.
Yeah, so I would definitely like to volunteer for this working group. I think it's I feel a little uncomfortable doing this, but I think we have to draw attention to the fact that this is another action where there hasn't been a follow through. And this isn't the first time this has happened with this committee, where we've said we're going to go away, we're going to do something, and it hasn't happened. And I do worry about that, Patrick. You know, I do worry about the fact that that's happening with this committee quite consistently now. And as chair, you do receive quite a significant allowance that should enable you to take actions forward outside of this meeting, chase officers up, make sure commitments are followed through on. And that doesn't seem to have happened since this committee was established and you took over as chair. And it's nothing personal, but I would like some reassurance that you are capable of stepping up your work outside of these meetings to help make sure this committee is run a bit more effectively and proactively. Because I think it is embarrassing we're in a situation now where it takes months for actions to be completed after these meetings, not weeks.
Yeah, I understand the comment, Joe, but what you don't know is the work that has gone on behind the scenes in order to get the thing set up. There has been fairly regular communications between myself and the Democratic Services team in order to get this set up. And it's not for the want of trying, but you have to fit in the commitments of the Democratic Services team and the officers concerned. And it has taken much longer than I would have liked. But it's not for the want of pressure and applying. That work has been done behind the scenes. But all committees are facing the same problems in terms of getting these kind of committees up and running. But we have got it set up now, and the first meeting will be on the 11th of December.
I think just in future, when things begin to go off track and we're not going to be able to work to the timescales that we should be, it would be good if you kept the rest of us on the committee in the loop. It would just have been nice to know that things were going awry with the forward plan, with this working group, and I think that is a reasonable expectation.
Understood. So the next item on the agenda is the forward plan. Are there any comments anybody wants to make on the forward plan?
Yeah, just to bring the committee's attention to Appendix B on the report, that is your actual current forward plan. So you're being asked to review it and confirm it or make any amendments. Thank you.
Okay, so anybody wants to identify anything that they think we should be looking at, just let us know and we'll see how we can fit that into the forward plan. So we've got the dates set for the rest of the other meetings there in the diary. So I'm now going to formally close the meeting, but before doing that, we just need to check what we want to do about the ICB.
Yeah, I've just messaged David just to see if there were any issues or if there's anything, because he hasn't let me, he didn't let me know that he's dropped off, so I don't know whether he's had issues with it. In terms, sorry, can we just, if we finish the meeting, because the briefing was an informal session, so.
Okay, we're just going to formally close the public part of the meeting. Thank you for everybody, and thanks for all the people that have tuned in. And we'll deal with the ICB issue offline. Thank you very much.